Welcome to BCNephro. This is BC. Today I'm going to give you my approach to hypertension. As a nephrologist, I'm often consulted to see patients with difficult to control or resistant hypertension. These are some of the things I think about doing. First, a 24-hour ambulatory blood pressure monitor, then assessment of kidney function and electrolytes with a metabolic panel, assessment for other evidence of kidney disease with a urinalysis and renal ultrasound, screening for secondary causes with an aldosterone-renin ratio and plasma-free metanephrines, and of course a careful medication review to see if there's medication causes of hypertension or a suboptimal antihypertensive regimen. One of the first things I think about doing is a 24-hour ambulatory blood pressure monitor. This is to exclude pseudo-resistant hypertension, a common cause being white coat hypertension or white coat effect. Other causes of pseudo-resistance include inaccurate blood pressure technique, the cuff being too small as one example, not adherence to medications, or a suboptimal antihypertensive combination. What am I looking for? With the metabolic panel and urinalysis, I'm looking to screen for some secondary causes of hypertension. The most common secondary cause of hypertension is kidney disease, and also looking for evidence of hyperaldosteronism, specifically a hypokalemic alkalosis. One test I typically do is a renal ultrasound. What am I looking for? Well, I'm looking for structural kidney disease, such as polycystic kidney disease, chronic hydronephrosis. I'm also looking for renal asymmetry, which could be a clue to renal artery stenosis. I typically don't do a renal artery Doppler. I think renal artery stenosis is overly looked for. I only do screen for renal artery stenosis if I have another clue and have a high suspicion of this and I cannot control it medically. I find an aldosterone-renin ratio very helpful. First, as a screen for primary hyperaldosteronism. This has an elevated ratio with an elevated aldosterone. Also, even if the screen is not positive, you can find low renin hypertension, which suggests a need for a diuretic, or high renin hypertension, which may support the diagnosis of renal artery stenosis. Pheochromocytoma is rare, but if I'm going to screen for it, I use plasma-free metanephrines. The thing to remember about plasma-free metanephrines is in pheochromocytoma, they're very high, greater than 4 times the upper limit of normal. Milder elevations are often due for other reasons. Of course, a careful medication review is crucial, both to look for medications that can cause hypertension, some examples being NSAIDs, angiogenesis inhibitors, tyrosine kinase inhibitors, decongestants, stimulants, and atypical antipsychotics, as well as to look to make sure there is an optimal BP regimen. This means there has to be an appropriate diuretic, and also using synergistic blood pressure medications. RAS blockers and thiazides, and RAS blockers and calcium channel blockers are synergistic. RAS blockers and beta blockers are not synergistic. Here's an example of an optimal stepped approach to treat hypertension. Step 1 is use of a RAS blocker or thiazide. Step 2, use the alternative agent, not used in class 1. Step 3 would be to use a dihydropyridine calcium channel blocker such as amlodipine. Step 4 actually is to add spironolactone. Step 5 is a vasodilating beta blocker such as carvedilol or nivedilol. Step 6, you're thinking about some of the more potent agents such as loop diuretics, minoxidil, hydralazine, an alpha blocker, or clonidine. As a nephrologist, what tricks do I have up to my sleeve to help treat resistant hypertensive cases? First, change hydrochlorothiazide to chlorthalidone. Chlorthalidone is more potent and longer acting. If the patient's on a loop diuretic like furosemide, you can change that to torsemide, which is also longer acting. Add spironolactone, which is often helpful in resistant hypertension. Use a dihydropyridine calcium channel blocker as opposed to a non-dihydropyridine like diltiazem. Also, I found that nifedipine extended release is much more effective than amlodipine. and then use a vasodilating beta blocker. As opposed to metoprolol or atenolol, use something like carbendazole or nipocalimab. So there you have it, a nephrologist's approach to resistant hypertension. For more information, visit bcnephro.com.